if you think your hospital has your best interest at heart because they have very nice radio commercials and television commercials, think again. Their fiduciary duty is to keep the hospital financially viable.
Majority of things in hospital setting controlled, but also the timing of birth. Everything is so quick. When they insert the balloon, right? It's like, okay, maximum. Oh, you'll give birth by 6 o'clock. How do you know these things? They know because they practice this on so many women.
It would just roll off my tongue, and I would say things like, "Do you have any meds? Take any meds? No. Do you have any allergies? No. Do you have any other medical problems?" And for the first time in 35 years, a woman looked at me and she said, "What's the first one?"
When you're in that delivery room, you're in fear and it's very scary and it's understandable, but don't ever be led by that.
You always fear what you don't understand. And the reason that we keep things a mystery sometimes is so that we can control you.
How many women I know that after one birth, they're like, I'm done. It was a horrible experience. I don't want to go through this ever again. But every single person that I've talked to that has had home deliveries, they have nothing but wonderful things to say. Hello, everyone. Thank you for joining me today. Today's episode is with Dr. Stuart James, obstetrician and gynecologist, an OB-GYN highly respected. He completed his medical school here in the States and completed his residency at Cedars-Sinai Hospital. He has been an obstetrician for over 42 years. He's reteaching twin birth. He supports midwives and home birth. He's an advocate of midwives and a severe advocate of home birthing in the natural way possible. And this episode was quite interesting because we delved into birth and why it's considered a disease nowadays instead of a God-given process for women. Women have been fearing birth nowadays. The statistics are showing that pregnancies are lower. Childbirth is highly lower than before. I mean, I'm sure you guys know it too. The birth rates have calmed down substantially. And it's all because of the fear and anxiety around giving birth. Today's episode was all about how women can gain control in the delivery room and what that really looks like. We dived into the pros and cons of home birth, midwives, home birthing, hospitals, and etc. So I think this episode is really important for anybody that's expecting, anyone that's wanting to learn about birth, and anyone in general that really wants to dive into birth and understand the concept of birth giving and how beautiful it is instead of looking at it as a fear factor. Enjoy this episode and make sure to subscribe to the channel as it's super beneficial and a support system for me. Thank you guys. Dr. Stu, it's so nice to have you on today. Thank
This
you
is a
for
pleasure for
joining
me to be in Los Angeles and be in your studio.
Yes.
It's a real treat.
How's your drive?
Oh, the drive was easy. I've been traveling
Good.
a lot. I was just done teaching in Minnesota, up in Bemidji. There was a traditional home birth conference there with a lot of indigenous midwives. The Ojibwe tribe is up there, and there are Amish people up there. And then speaking of Amish, I went to Michigan and I stayed with the Amish family and taught there. And then I
Wow.
came back home and had a little bit of recreation. I went to Vegas and I played a little bit in the World Series of Poker, and I actually cashed, so that's exciting for me. And then yesterday I drove to LA, and I'm going to spend a few days in LA with my family. We're celebrating on Sunday Father's Day, my
Yes.
ex-wife's birthday, my daughter-in-law's birthday, and my other son's engagement. And we're doing a dinner with all of us
Oh my
together.
God, lots
that'll
of
be fun. Yeah,
fun.
great things happening. It's good.
Blessing.
And the drive is fine because that's where I listen to things like, your YouTube videos, your
Yes.
podcast. So
That's wonderful.
right.
Could you tell us a little bit about your background? I mean, I'm sure you don't need an introduction. I mean, you're pretty
Well,
prestigious yourself,
I don't
but
know that your
just
listeners know too much
please,
about
we
me,
would love
but
to hear.
I have a very sort of unusual path to where I am today, and I'll try to be brief. Uh, I grew up in Minnesota. I went to college. I had no direction, like a lot of people go to college. I had no direction. When I was a junior and a biology major, some of my friends decided to go pre-med, and I'm the son of a Jewish mother, so that was really one of the only choices I had. And I got into medical school at the University of Minnesota, and in your third year of medical school, you have to make a decision that you're absolutely not prepared for. And the first 2 years of medical school are essentially classroom didactic and some anatomy lab. And the second 2 years, you do rotations in different specialties. Like you have some core skills, like you have to do pediatrics and internal medicine and surgery and OB-GYN. And then you get electives like dermatology and ear, nose, and throat and neurology, that sort of thing. But in the third year, as you're finishing your third year, you have to apply for residency programs, and you don't know anything.
Hmm.
And yet this is something that you probably will be stuck doing the rest of your life. And medical students are enthusiastic, but they're naive. And I came off a rotation as a third year medical student on hematology oncology, which I found really depressing. It was a pediatric rotation. Kids had cancers,
Oh,
leukemias, lymphomas. And then my next rotation happened to be obstetrics. And I was up at 3 in the morning catching a baby instead of pushing chemotherapy. And it was delightful for me. And then I realized that I really liked a specialty that had what's called longitudinal care. Longitudinal care is where you're taking some care of somebody over time.
wow.
A lot of the specialties are like whack-a-mole, all right? You break your arm, I set your arm. You have an appendicitis, I'm a surgeon, I take out your appendix. But I never see you again. Internal medicine, family practice, and OB-GYN are really the major three specialties that see people over time. And I really liked surgery, and so the other two didn't have that. I like the fact that OB-GYN has a little bit of psychiatry, a little bit of endocrinology, a little bit of internal medicine, plus you get the benefit of catching babies, where you have I call them clients now, but we call them patients, who really are happy to see you generally, and they get well, and you see the results of your work, and it's very satisfying.
Very. I'm
And at
sure.
that time, as I said, you're naive, so you don't think about liability, you don't think about hours, you don't think about that sort of thing. You just think about what would I like to do. And so I applied for a residency program. I matched in Southern California at Cedars-Sinai Medical Center here in Los Angeles, which was one of those sliding door moments in your life. On the third Wednesday of March, all fourth year medical students open up an envelope, and it tells them where they're going to be spending their training. And so, had I matched in Iowa or had I matched in Colorado, I can imagine my life would have been completely different. But I matched in Southern California. I came here with no intention of staying in California, but I got a really good job offer, and I ended up spending 40 years here, and only recently just left California, sort of semi-retired from active practice. But I came out very medicalized, like everybody who comes out of residency, thinking that birth is a illness or disease
Yes.
that needs to be treated, and if it wasn't for modern medicine, women themselves would collapse. They're not capable. They're essentially vessels, not humans. And we save babies. That's how we're trained. That and so I began to practice that way. And I was the crazy guy in the hazmat suit, with your legs up in stirrups, covering you with sterile drapes, washing off your bottom, catching your baby, cutting the cord immediately, showing you the baby, and walking it over to the warmer, and never thinking about pretty much everything I just described is unnecessary. And yet that's how we were trained to do it. But I had the good fortune of being approached by some midwives early in my career and asked to take their home birth transports. Now, I knew nothing about home birth. I knew nothing or very little about midwifery. I probably, like most OB-GYNs, thought it was foolish to give birth at home. How can you do that? What if this happens? What if that happens? But I did it because medicine back then was a bit different. You didn't come out and get a job, work a shift like doctors do now.
Hmm.
You came out and you built your own practice. You hustled. You covered other doctors' practices. You covered ERs. You worked at free clinics. To build your practice from scratch. And so I said yes, and it was one of the best decisions that ever happened to me, because slowly but surely over the next few years, I began to see a whole nother way
Mm.
of practicing, a whole nother approach to pregnancy as normal, which occasionally needs help. And so I began to spend time with the midwives and go to some of their meetings and just listen to them. And I met their patients, and they were all very smart, intelligent women who had made this decision not because they were hippies and didn't shave their armpits and stuff like that. It was because they had thought this through, and they really didn't want what the hospital had to offer. And it made me start to look at what I was doing. And then after about 10 years in practice, I started a collaborative midwifery practice with two certified nurse midwives in Ventura County. Cedars-Sinai at that time did not allow midwives to have privileges, and I wanted to have a collaborative practice. And so we went out to Ventura County, and for 15 years, we had a really good thing going on there. We had very low C-section rate, about 7%. The midwives took care of all the normal stuff, whether it be the annual exams, the pap smears, the prenatal visits, catching the normal babies. And if a woman had an abnormal pap smear, needed a colposcopy, I took care of that. If she had an ectopic pregnancy, I took care of that. If she needed a C-section or forceps delivery, or if she had breech or twins, I took care of that. And that, to me, that was a really good model to practice, yet we were really never accepted in the community.
Why do you think that is?
Um, Fear. You always fear what you don't understand. And the doctors, especially the anesthesiologists and the pediatricians, even more so than the other OBs who we'd be competing against, were very nervous about what we did. You know, our midwives patients did not want epidurals. They did not want vitamin K or hepatitis B vaccine in their babies. They wanted to go home 6 hours after they gave birth. And that made the staff nervous because the other OBs there were all very old school. They had section rates 3 to 4 times higher than ours. They, you know, a woman broke her bag of waters. They told them to immediately come to the hospital rather than they would call us. We would ask them a couple questions. If everything was fine, we'd say, okay, go back to bed. Talk to you tomorrow. Don't worry about it. It's perfectly fine. And their induction rate and their C-section rate was high, and their outcomes were not as good as ours. And of course, that makes people upset
You're right.
because ultimately it wasn't about what's best for the women of the community. It's what's best for the hospital and the local doctors' practices.
Right.
Listen, hospitals make more money when you come in and get induced, when you have an epidural, when you have blood tests you don't need, when they can charge for these things.
Unnecessary things.
Right. There's no money in not doing something. And so our clients came in and they didn't want these things. They didn't want vaccines. They didn't want
Mhm.
vitamin K. You know, that doesn't make the hospital's administration very happy. And it took 15 years, but they've eventually found a way to get rid of us. First, they banned VBAC, which is vaginal birth after cesarean, which is completely unethical to ban VBAC. It's a perfectly
Natural.
reasonable choice,
Right.
evidence supported and everything. And then they kicked the midwives off staff at that hospital, which was right next to our office in Camarillo. And then they tried to ban breech delivery. I'd done 3 breech deliveries in June of 2010, and none of the they were all fine. There was no problem with any of them. Yet it made the nurses really nervous. And I got a call from the chairman of the department, said you need to stop doing breeches. And I said, well, I have a document here that you signed that gives me permission to do breech delivery. It's called a privileging sheet. And he said, well, it doesn't matter. If you do any more, we're going to suspend you. So I had a decision to make. Am I going to fight them or am I going to move on? And I had very wise advisors, including a lot of my midwife friends, who told me that you can't fight a hospital. It costs you a lot of money. It's an administrative process. People who don't understand that, it's not your legal process. It's not like you have an independent judge or jury. You are accused, tried, and judged by the same organization. So you almost are certainly going to lose. And if you lose, then you get reported to the National Practitioner Data Bank, and then this happens and that happens. So the choice was to just let my privileges expire and move on. And I started to go to home births. And even after 25 years of backing midwives and supporting home birth and being supportive of the decisions, I had never been to one. And I was a little nervous, I have to say, the first couple I went to. But my own patients who were due after the time that my privileges were going to expire, because doctors have to renew their privileges every 2 years, and they weren't going to renew mine. And they can legally do that. And that's fine. It's their football. They can play with it and they can take it home with them. But even after all those years, I had never been to a home birth. And so I was a little bit concerned about that. But my own patients said to me, listen, we've always wanted a home birth, Dr. Fishbein, but we really wanted you, so we decided to stay in the hospital. We're thrilled. So come to our house and do a home birth with us. And I did, always with a midwife together with me. My whole career, I never really went to a birth without a team. And that included a midwife and a midwife student and usually a doula. And we had a great team. And then I began to practice all over Southern California. So if I was in San Diego or Orange County, then I would have different midwives and different teams. But I got to know pretty much everybody. And for 13 years, I practiced in the home setting. Then I got bolder. And I said, well, if I can do births at home, why can't I do breeches at home? Why can't I do twins at home? Why can't I do type 1 diabetics at home? Why do they need to be in the hospital? Why do they need to have...
all are, I mean, like when you talk to a physician at a hospital, all those that you just listed are named as high risk pregnancies.
Yeah. Yeah. I have a real good talk about this. I go around the country now and I teach, around the world actually, and I teach a 2-day seminar on breech and twin skills. And one of the things I talk about before we get into the actual skills is nomenclature and language. And one of the things we talk about is high risk.
Hmm.
And I ask my attendees, like, so, okay, guys, what's high risk? And they'll rattle off, oh, diabetes is high risk, hypertension is high risk.
Right.
I said, is it a number?
Mm.
And then they think about it for a while, and I said, I'll make it easy for you. It's not really a number. It's whatever the doctor's uncomfortable with. They label it as high risk. Age 35 is not high risk, but yet you're labeled high risk.
Correct.
Having a previous C-section doesn't really change anything, but you're labeled high risk. Some things that have far greater risk, like inductions of labor leading to interventions leading to the cesarean section, the risk of that happening is much higher than someone laboring with a previous cesarean section, but that's not labeled high risk. So high risk is what they don't like to do, and so it's a label. It's not, It doesn't really have a meaning. It's like also community standard. What does community standard mean? Does that mean what everybody in your zip code does? Does it mean what OBs do? Does it mean what midwives do? Who decides? Is it the hospital administration that decides? Is it the national organizations that decide? Is it the malpractice attorneys, the insurance companies? Who decides? Ultimately, my community is not the OB community. So, and midwives are in the same boat, but yet they're held to standards that aren't theirs because people have lost their way. They think about birth again as a disease or a medical problem that needs treatment. And whereas midwives look at birth as, or pregnancy as a normal function of the human body, and they accept uncertainty, but they don't try to manage things. Listen to the terminology. We're going to manage your labor. What does that even mean? This is how doctors speak. If you hear the words that come out of their mouths.
But these are the things that have made pregnancy so fearful among women.
Yes.
I just recently had a podcast last week with one of my friends, clinical psychologist. She was petrified of pregnancy for a long time because of everything you hear. Epidurals going wrong, all these tests, these gluten tests, it's just, I mean, my grandma gave birth to all 6 kids at home.
Yep.
Perfectly fine. And her mom and so on. So what happened? Why are these changes? What are
the
all
medical
these
model
tests?
fears birth because they're trained that way, and then they project their fear onto the women of our country. If you look at the Amish population, if you look at women from Central America, they may even have more morbidity in their population, yet they have very little fear of childbirth. They just accept it as a part of life.
Little fear, and also they have no issues having children. And I think that stops you. This fear stops you. How many women I know that after one birth, they're like, I'm done. It was a horrible experience. I don't want to go through this ever again. But every single person that I've talked to that has had home deliveries, midwives, they have nothing but wonderful things to say.
Listen, there can be bad outcomes in any setting. So
Correct.
Once the sperm and egg together, there's no guarantee how the outcome's going to happen. But there are doctors on the internet who are really anti-home birth, and they're very popular on Instagram. They've got a large following. And that one recently posted something about, people think that hospital births are so dangerous, but look at the maternal mortality and stuff in 1900. So they're making a false comparison. They're comparing 2024 to 1900. When 1900, we didn't even know germ theory. We didn't know about antibiotics. We didn't know anything about anything at that point. Compare 2024 to 1970. In 1970, the C-section rate in the United States was 5%. It's now about 32%.
Oh my God.
So there's a 500% increase in the cesarean section rate. So you think, gosh, with all those cesarean sections, we must have lower maternal and fetal and neonatal mortality, right? Wrong. If anything, it's slightly increased, but even if it's plateaued, you essentially have done millions of unnecessary interventions and C-sections on women for no visible benefit and actual evidence of non-benefit, and yet this trend continues. So these doctors who project this anxiety onto them, it's because that's how they were trained. And I could really get into it. It's always, they always say, follow the money.
Mm-hmm.
Okay. Follow the money here. This is, it's a $1 billion industry.
Wow.
And who runs, this could be controversial, but people can take it and try to analyze it. But really, who runs obstetrics nowadays? It's maternal fetal medicine doctors. They're called high-risk specialists, right? They're the ones that run the departments. They're the ones that train the future doctors. When I was a resident, and again, now I start to sound like my dad. Okay, in my day, we did this, and it cost $0.25 to go to the movies. No, but when I was a resident, if a woman had diabetes, we learned how to take care of that.
Mm-hmm.
If she had hypothyroidism, we learned how to take care of that. Now, OBs are trained that no matter what a woman has, she needs to consult with a specialist.
Yes.
So every single woman in pregnancy, just about in the medical birth model, never makes it through without seeing a maternal fetal medicine doctor for at least something. Maybe it's just her 20-week ultrasound, but there's always something that they're consulting with, because I think the people that are training the future doctors are training them to be dependent on the maternal fetal medicine specialty, and they make a fortune. A typical MFM, if they scan your patient like 2 or 3 times, makes more money
Mm-hmm.
than you do for taking care of the woman and doing her delivery in the insurance reimbursement sort of world. And then there's the thing that how they speak to a woman. And I'm not sure they do this maliciously. I just think they don't even think about how this stuff comes out of their mouth. And I'll give you 2 examples. One is a woman comes in at 20 weeks and she gets a 20-week ultrasound. And your listeners will know that. Anybody who's had a baby probably gets a 20-week ultrasound. And the baby looks perfect. And it's growing perfect. And the placenta's in the right spot. But there's one little echogenic focus in the heart, or one little dilation in part of the brain. Now, everyone knows that in the face of normal genetics and normal everything else, that means absolutely nothing.
Mm-hmm. But they freak you out.
But they will tell you that, oh, your baby looks perfect, but there's this one little echogenic focus.
Correct.
I want to see you back in 6 weeks.
That sends you into this spiral.
So rather than hearing the part about how your baby is perfect, what are they thinking about for 6 weeks? They're thinking about something's wrong with my baby's heart.
Yeah.
And the way we're trained is to believe that pregnancy is a medical problem. In ACOG's own guidelines, there's a statement in several of them that say pregnancy itself is a high-risk condition. So that's how the prism by which they see pregnancy. And here's something that, Here's something that happened to me about 5 years ago, after almost 35 years in practice. Some woman finally called me on something that I had no idea that I was doing. But when you take a history, somebody comes in for the first time you're meeting them, you ask them, well, why are you here? And they tell you why you're here. And then you ask a bunch of questions about that.
Mm-hmm.
And then you ask them about what medicines they're on. Do they have any allergies? What's called past medical history, past surgical history, and maybe family history, and then something called review of systems. That's basically how we're trained to take a history. So when a woman came to see me with her pregnancy, and I got to past medical history, it would just roll off my tongue, and I would say things like, do you have any meds? Take any meds? No. Do you have any allergies? No. Do you have any other medical problems? And for the first time in 35 years, a woman looked at me and she said, what's the first one?
Oh, wow. Mm-hmm.
Do you have any other medical problems? Me not even realizing that I'm considering her pregnancy to be a medical problem. And that's me. And I was already evolved into the person that doesn't look at pregnancy at first as a medical problem. Yet it was still built into me. And even to this day, I have part of that doctor stuff that still comes out. And midwives tend to laugh at me sometimes when I do that. But it is the way they're indoctrinated. And so why do women in community fear birth? Well, look at how it's portrayed in TV and movies and even on in the news and stuff. The stories about the outcomes that happen that are good and normal are not in the news.
Mm-hmm.
How many times in the newspaper you read about planes that landed safely today? You don't.
Hmm. It's
But
always
one
the next
plane
one.
whose wheel fell off, you got video
Correct.
running constantly 24/7.
So then this leads me to this question. What are some of the pros and cons of hospital birth and some of the pros and cons of having births with midwives?
Okay. Hospital birth is obviously necessary, and ultimately the system is broken, or people will say it's not even broken, the system is just the way it is, and it needs to be like thrown out. And ideally that would be great. And people could have another birthing alternative. The problem, of course, is that I'm just coming up with a number, say 10 to 15% of women really need what the hospital has to offer. And if you took the other 85% away, the hospitals would close their units. They wouldn't be able to keep them open. So we have this dilemma.
Hmm.
Hospitals are great at taking care of problems, but that's when you have a real problem. Like a woman is at 29 weeks and she's in preterm labor. A woman develops severe preeclampsia.
Mm.
A woman has placenta previa, or even, I won't even talk about placenta accreta, where the placenta grows into the wall. We're seeing more and more of those. There's been a fourfold increase in that in the last 30 years because it parallels the rise in C-section rate.
Oh,
So the treatments that we offer women have downstream consequences that are really never considered. But the hospital is obviously necessary for certain things. But the knee jerk that it's necessary for a woman who happens to be diabetic, why? Not all diabetics are exactly the same,
true.
but the medical model doesn't allow that. They work on an algorithm, Edith. Look at, they have nurses in the hospital that are well trained.
Hmm.
They have doctors in the hospital who are well trained, are past their boards, are licensed to practice, and yet they're not free to practice the way they're trained. They have to
Right.
follow the hospital's
Regulation.
algorithm.
But also this though, why is there such difficulty of giving or helping a woman with breech pregnancy? If they're so skilled, what is the danger for
Well, they're
these
not
breech,
skilled. Yeah.
right?
Well, the de-skilling of the physician, as I said earlier, it starts with the way they're trained with MFMs to sort of cow them away from the idea that you could even take care of somebody who's diabetic without a consult, or
Mhm.
somebody who's hypertensive without a consult.
Hmm.
And by the way, the reimbursement rate for doctors makes it even more, all the forces are such that they push women toward doing those things. So the doctor doesn't get paid more to take care of a woman with diabetes. But the MFM or the diabetologist, they get paid to take care of her diabetes. But if I'm her OB, I can't bill extra for that. So everything about today's system is wrong. And when I say everything, I'm not being hyperbolic. I list a whole list of things that the hospital does to you when you get admitted to the hospital. And I ask the people that attend my seminar, so look at that list now and tell me if any one of those things is done for the benefit of the woman.
No, I think, well, from my experience, it's all for the baby, right? Doctors will say, the most important thing is that we get that baby out safe. Like
Right.
my own doctor said that to me.
Right.
What about me?
Yeah, because the journey doesn't matter.
The journey doesn't
It's only
matter.
a destination.
Exactly.
And so you asked about breech and twin delivery. They're de-skilling them. They've gone to cesarean section. Most breech babies can be delivered vaginally safely. And the data actually supports that. But this is data that they choose to ignore.
Why do you think that is? Money?
Fear and money, yeah, and fear of litigation and money, yeah. And expediency. Boy, if you have a lady who's breech and you're going to get paid the same whether you bring her in at 7:30 on a Tuesday and do a C-section on her and out pay 8:15, or you have to, you're going to let her labor and your hospital has a policy that says you have to be here the entire time she's laboring because she's breech, and you get paid the same. Why would you encourage her to have a breech delivery? And so they don't learn the skills, and then they may even work at a hospital or in a group where the group says, you may do breech deliveries, Dr. Fishbein, but our group doesn't support it, so you can't do them.
But is this taught in residency?
No, it's not being taught in most residency programs anymore.
And what are the risks of delivering with breech babies?
Well, that's a whole podcast in and of itself. But if you look at the world literature, if you improperly selected breech, and there are criteria that we use to properly select a term breech pregnancy, the risks are almost negligible compared to vaginal delivery.
Mm.
The mistake that a lot of papers make is they'll compare vaginal breech delivery to cesarean for breech delivery. But you shouldn't compare those. You should compare vaginal breech delivery to head down vaginal delivery. And the difference is extremely small. And the best guidelines, if your listeners want to look at that, are put out by the Royal College of Obstetrics and Gynecology in 2017. They're called the Green Top Guidelines. And they talk about the risks of these things in relative risk. But you also, you have to convert relative risk to actual risk. Relative risk doesn't mean something. If something's 4 times riskier than something else, that sounds bad. But take it this way. If something happens 1 in a million times and it's 4 times riskier, that means it's 1 in 250,000, which is still essentially 0. So until you know what the denominator is, then a lot of times statistics are used as, for lack of a better term, medical trickery. To coerce you, to funnel you, whether it's subtle or overt, to down a path that the physician wants to take because it's more comfortable for the physician. The physician fears breech delivery, therefore they don't want you to choose that, as opposed to being the ethical physician would say, you know what? Breech delivery in the literature is actually a reasonable choice when properly selected with a skilled practitioner, but I'm not skilled, so you need to find somebody else. That would be an ethical thing to say. But what they'll tell them is, oh, the head will get stuck, or the cord will prolapse, and your baby will have brain damage, and that's not true. That's not true any more so than it is with a head down baby.
Correct.
And yet, you know, they skew their counseling. Listen, this is rampant. This just isn't in medicine. This is in everything in our lives right now. We are being gaslit constantly about everything.
Everything.
Right. This isn't just obstetrics. I mean, people haven't opened their eyes in the last 3 or 4 years about the gaslighting that's gone on with the whole COVID vaccine issue. Then there's no hope for you. There's no hope.
Well, then help me understand, and our audience, this, Dr. Stu, when a woman does want to do, proceed with home birth or with midwives, the usual comeback to that is, what if something goes wrong?
Yep.
And I know you hear this all the time, and it's so frustrating because anything could go wrong at a hospital too. I've had several friends that have had severe issues at hospital births. So how do you soothe someone that wants to do home birth but is...
Well, that's an interesting question, and we're going to only scratch the surface here. My co-host Bliss and I on our podcast, once every 2 months, we have a webinar, which we call Bringing the Home Birth Hesitant on Board. So I'm very well versed in these questions because we get them all the time. But when you leave Mother Nature alone, nature designs birth over eons. It's been designed. The communication, the hormonal communication between mother and baby for 9 months, and the signals that baby sends mom and mom sends baby during labor that everything's okay and baby's fine, and getting mom's hormones. This is well designed. And when you leave nature alone, things rarely go wrong suddenly. You can generally see them coming. And as, again, somebody who's worked in the hospital for 28 years and then 13 years in the home setting, I can tell you that the sudden deterioration of fetal status that you sometimes see in the hospital doesn't happen at home, but extremely rarely. Yes, there will be occasions where that happens, but it doesn't necessarily mean the outcome's going to be worse than if you were in a hospital. So let me explain that for a second.
Sure.
So when you don't mess with Mother Nature, you don't generally see this whole thing where you have this baby suddenly deteriorate. The problem is in the hospital, because they're interfering with Mother Nature from the minute you get in your car to drive there until the moment you put your baby in the car seat to drive home. Pretty much everything they do is antithetical to nature's design. It causes this whole cascade of interventions. And then you're more likely to end up with a baby in the NICU or an emergency procedure, emergency C-section or vacuum delivery, because of the way that you were treated in the hospital, because of you're not moving fast enough, because of the multiple vaginal exams, because of the constant interruption, because of the epidural interferes with mother-baby communication. But why wouldn't you want to have an epidural? You would never have a tooth pulled without Novocaine. Why would you have a baby without an epidural? I wrote a whole blog once.
That's my next question after this.
All right, we'll get to that. So we end up with a situation where that's a very legitimate question that asks, and it's usually asked by the dads, by the way.
Yes.
The fathers ask that question because safety and money are they're
Yeah.
our concern.
Yeah.
Uh, but that's what midwives are trained for. Midwives are experts in normal birthing.
More than
Oh, doctors are experts in problem birthing. They don't even
Yes.
know normal birthing. They don't see normal birthing. Watch The Business of Being Born. Watch Ricky Lake and Abby Epstein's movie, and you'll see they don't know that. But midwives are trained in normal birthing, and as an expert in normal birthing, when something isn't normal, you see it right away. The analogy that I often use is if you lived in the same house for 20 years and you go out for dinner and you come home and you open the front door and the chair in the front hall has moved 3 inches from where it normally is.
You notice
You
it
notice
right
it
away.
right away. You don't know why. Did the dog hit it? Was there an earthquake? Did someone break in the house? You don't know why, but you know something's not right. If I came into your house as a guest for the first time, I have no idea that that chair was in the wrong place. Right? It's a very simple thing. Midwives are experts in, now, are there good midwives and bad midwives? Of course. And are there good OBs and bad OBs? Of course. Are there good MFMs and bad FMs? Of course. And how do you know? You don't. You don't. You know, and maybe your girlfriend had a great experience with this doctor, but maybe your girlfriend's personality or her desires are different than yours. So you have to interview people and you have to ask questions. And we've done a podcast, and the Down to Birth people have done a podcast about, how to interview your doctor, what questions to ask.
That's a
What
great
are red
question.
flags? How do they answer your question? Do you feel better when you leave your doctor's appointment, or worse? Did your questions get answered? Did your doctor give you the time? A big difference between the midwifery model of care and the medical model of care is the midwifery model of care. A prenatal visit is generally 60 minutes long.
Oh, wow. That's
And a medical
wonderful.
model of care, it might be 6 to 10 minutes long.
Correct. They don't have time.
They don't
They
have
don't have
time
time.
because of the medical design. Not the medical design, the financial design, the office
patient
overhead.
load.
You have to do volume in order to keep up in a system that has third-party payers. If doctors could charge what they needed, they could be less busy, but they can't. So they have to take what some businessman who's got a $500,000 salary and probably a nice private jet is telling them to do.
Wow, yeah.
That's part of that's part of the problem. I know I'm having flight of ideas here almost, because you ask these questions and I've been asked them so often that so many thoughts come into my head. So I hope I'm answering them to your satisfaction.
No, you are. I love them. I have a lot, and you're hitting all because I'm reading through them. I'm like, oh, you answered this already. One question that I have: many of the hospitals do these glucose tests during the end of the pregnancies. What are these tests about? Because I literally rejected every single test that was given, especially this glucose one. It doesn't make sense to me to give an unborn child that much sugar to
Yeah,
see
it's not
if
how you eat anyway.
it's just it doesn't make sense to me. So what advice do you give moms that do reject this test? Are they doing the right thing?
Well, yeah, the problem with testing in general is that it's often set up to catch everyone who's got the problem, but ends up catching a lot of people who don't, or what are called false positives.
Wouldn't these develop problems though? Some of these tests?
Well, hang on a second. Let me just, for your listeners, just
Yes.
there's a thing called sensitivity and a thing called specificity. People, what these things are, but you probably may not have heard it that way. A sensitive test is a test that's positive when something is wrong. So the best example of that would be like a metal detector. All right. If you have a gun, metal detector is going to pick it up. A specific test is a test that's negative when nothing is wrong. So the metal detector, highly sensitive, but low specificity. Keys, belt buckle, coins in your pocket, those sort of things are also going to ring it. So there's going to be a lot of false positives. The problem with tests like the glucose screening test is not only just is it metabolically weird because you don't eat that way, but it's set up to catch, so it has a lot of false positives, which then get people labeled.
Yes.
And you may be labeled as, okay, well, you failed your first test. Now you have to do this other test.
Yeah.
But does the label that you failed the first test ever go away? And what does that do to your psyche, that you failed a test?
Oh,
and now you're thinking that you might have a problem. And then you've read about diabetes in pregnancy, but you've not really read the facts about it because you read what ACOG or whatever else. They make it seem like it's this really big deal. And on rare occasions it can be, but most of the time it isn't. Yet, because of the algorithms by which doctors practice off of, all diabetics are treated on the same pathway. And it becomes insane because most people who fail that test are not diabetic, and they need, and they can be managed with diet alone. So here's the question. Why don't we just get people on healthy diets in the first, or even before they're pregnant, if we can get a hold of them, but at the 10-week visit? Why don't we spend time talking about nutrition? Well, midwives actually do, because they have an hour to do it in.
Correct.
And doctors don't. So they start talking about having you see a dietitian at 28 weeks when you failed your glucose test. This is another problem with the medical system. And the stuff that's in it, so don't do it.
I never did.
Now,
both
if you want to be tested, one of the good ways to test is to tell your doctor, you know what? I'd like you to draw my blood an hour after I eat a normal
Isn't that the
meal.
pancake test? They call it the pancake diet, right? Where you eat like a pancake with syrup.
No, they're telling you what to eat. I wouldn't even do that. I'd want to know, how do I respond to what I eat?
What I eat, yeah.
That makes more sense.
It does make more sense.
So, I mean, because maybe you don't eat pancakes. Maybe you don't eat 23 jelly beans or whatever it is. Maybe you eat very healthy.
Exactly.
And you eat low glycemic index carbs, and you eat a couple of eggs for breakfast with some bacon and maybe an English muffin or some, tomatoes. That's your breakfast. That is going to be different than someone has a bowl of cereal with some sugar on it and blueberries and, that sort of thing. You're going to have different.
Correct.
So
sugar levels, yeah.
These standardized tests, and by the way, it's really interesting. They give you the same amount whether you weigh 120 pounds or 320 pounds.
Mm-hmm. It's gnarly.
So think about that. Your volume of distribution is completely different. And a lot of times this gets into something that I often consider a mentor of mine who's an economist who's older now. His name is Tom Sowell. People want to look him up. They can look him up. But one of the things he talks about that's influenced me a lot is what's called stage one thinking. And that's thinking that doing something because it sounds good or feels good without ever asking the second question, which is, and then what happens if we do this? And like continuous fetal monitoring, that is a stage one thinking thing. They put it into place before it was ever tested to see if it actually does good. It felt like, if we monitor babies continuously, we'll prevent cerebral palsy. Well, how about testing it first before it becomes universally used? Because it didn't ever do that, as I talked about earlier. Mm-hmm. All it did was raise the C-section rate.
So then how do women take control then in situations like this? Because we are just scolded for rejecting every kind of test like this. And how do we take control of our pregnancy?
Just ask for explanations for things. And if you feel like the doctor is getting exasperated or doesn't have the time for that, wake up.
He's not the right doctor.
Yeah, get out of there. You're hiring them. Would you hire a painter to paint your house?
No.
And you said, I want coffee, tan coffee colored. He says, I'm giving you yellow.
No.
And no, you would never, you'd fire him immediately. So you can fire your caregiver and make pregnancy something that you value. And people say, well, I can't do that because I only have Medicaid, or I can't do that because my Blue Cross only lets me go to this group of people. It's like, no, it doesn't.
No, it doesn't.
You're choosing to not spend your own money. And that's a statement of how much you value it. And it's sort of it's a cultural thing. I don't blame people because they don't think, they get stuck in their box and they don't think out of their box. You save money to buy a car. You save money to go to college. You save money to have a wedding. Why not save money for your childbearing? And if you have to pay a little extra to see an out-of-network doctor, or pay a midwife because your insurance doesn't cover a midwife, or even if you go to a doctor, pay a midwife to do some prenatal visits with you so that you can see the different two models, and maybe your doctor only gives you 6 minutes, but you got 60 minutes with a midwife who can help you stay healthy in that doctor's practice and tell you and help you, guide you, along with hiring a doula, which is extremely important for a first-time mom especially, who can guide you along the way and give you the answers to the questions, do I really need to do that?
Yeah.
And here's the pros and cons, and they'll have the time to give you the pros and cons. It's all these other things. Do I need all these vaccines at 28 weeks? I'll give you a blunt answer. No, you need none of them, and you should take none of them, and you should take none of them ever.
Right.
The flu, the DTaP, which has got aluminum in it, the COVID vaccine, and then they want you to have the RSV vaccine at 34 weeks. None of those ever been tested for safety in a randomized placebo-controlled trial in any human being, let alone pregnant women, violating what's been a precept for eons, which is called the precautionary principle, which is that you don't test stuff on pregnant women. You just don't
You
do
just
that.
don't do that. It's
Right.
so unethical,
Yeah.
immoral to do things like this.
Yeah, they put people to death in Nuremberg trials for doing that sort of thing.
In a-
So and that's what's going on with women getting these vaccines and giving your newborn baby hepatitis vaccine, which is a sexually transmitted
yeah.
disease, and it contains 250 micrograms
Yes.
of aluminum
Tell him.
into a brand newborn baby. You got to be out of their mind. And by the way, if you
Speaking from
happen
my
to be one of those rare women who's hepatitis positive, your baby, you know, generally they're not going to benefit from the vaccine. They're going to benefit from getting H big. But now H big is pooled blood samples. It's caught from, you don't know if anybody who's donating that is carrying the spike protein around.
What about the vitamin K? Why do they push that on babies?
I
mean, I rejected both for my children, but I'm curious to know.
Vitamin K has a code that they can bill for.
Mm-hmm.
That's my simple answer. Because they're not, if you look at the numbers, the risk of a baby suffering from this very serious thing called late onset vitamin K dependent bleeding, or deficiency bleeding, I guess it's called. But the incidence is about 6 per 100,000 or 1 in 16,000. So if it happens, it's awful. But you're giving an injection intramuscularly to a baby of something that 15,999 times out of 16,000 they don't need. And if you read the package insert on that, it has a black box warning against intramuscular injection. And yet they give this dose to babies.
Meaning?
It can cause anaphylaxis.
Which is an eyesight condition?
No, anaphylaxis is an allergic reaction and possibly cardiac arrest and death. All right?
And this is on the insert?
It's what's called a black box insert. It's at the very top in a black box. It says, not for use intramuscularly. Now, also, vitamin K is, again, it's a one-dose vial. You're giving the same dose to a baby that weighs 6 pounds, one that weighs 9 pounds, and one that you might give to a 30-pound kid. There's no, you know, with other medicines for babies, they base it on their weight, like antibiotics and stuff like that, which is a whole nother discussion about antibiotics. But so vitamin K is probably something that it should be not used anymore. And I will be pilloried for that by a small percentage of people who may very well have had an incident where their kid has suffered from vitamin K dependent bleeding.
That's so
but
unfortunate.
We're giving something that's artificial. And here's the other thing that no one thinks about is, if vitamin K is so important for babies to have, how come they're born vitamin K deficient? How come nature hasn't figured out a way to get babies vitamin K if they're supposed to have vitamin K? Maybe they're not supposed to have blood that clots really good in the first 6 or 7 days of life. Maybe because they're developing increasing blood flow to their brain and their heart, and they do these little teeny blood vessels, and they don't want them to clot off. And maybe nature is taking care of it. Nature isn't stupid. Nature does things for a reason. And one of the reasons and things that nature did is make babies vitamin K deficient. And vitamin K is manufactured in your gut. And when you're colonized, babies colonized by the proper bacteria, mom's vagina, dad and mom's skin, that bacteria, then their bodies begin to make vitamin K, which is kind of an interesting thing. And again, in Jewish culture, babies who are circumcised, and this is not an endorsement for circumcision at all, but they wait till the 8th day of life. Why? Now, some people say, oh, because they want to make sure the baby's going to survive, and if it's a covenant with God, and blah, blah, blah. Maybe, but maybe the ancients knew that by the 8th day of life, babies' clotting mechanisms are kicked in and working fine on their own. This is all, you know, but it's all theoretical. You can't prove this sort of thing, but why would nature make babies vitamin K deficient if vitamin K was something they must have? Vitamin K is a money-making deal for you're giving 16,000 unnecessary doses.
Oh my gosh.
To every single baby gets vitamin K, and every single baby gets hepatitis vaccine. And you know what? Hospitals sometimes get kickbacks from pharmaceutical companies for the percentage of patients, or doctors' offices for the number of patients they have vaccinated, the percent they have vaccinated. I know this is a fact in pediatric offices, and I'm pretty sure it's true for hospitals too.
It is.
Right. So
it is.
If you think your hospital has your best interest at heart because they have very nice radio commercials and television commercials, think again. their fiduciary duty is to keep the hospital financially viable. And if they have to do more stuff than they need to keep it viable, that's what they're going to do. And I can't blame them. I blame the system for putting that kind of pressure on the chief financial
Yeah.
officer of a hospital to make these sort of things where we need to do all these things. Think about this. When you come into the hospital and you're in labor, they make you go into a room and they make you change into a hospital gown. First of all, why? What does a hospital gown
Well, they
signify?
said you never know what happens.
Well, why can't you wear your own jammies? Why can't you be naked? You put a hospital gown on because it's immediately disempowering. Secondly, they make you pee in a cup.
Yes.
Why? They draw blood on you. Why? Well, they'll say, oh, we got to know what your hemoglobin is, or we got to have a blood clot. Well, then how do we all do it at home? When we come to somebody in labor at home, we don't make them pee in a cup and we don't draw blood on them. And they do just fine. These things are done out of basically the long habit of not thinking it wrong and the fact that it generates financial revenue. Nobody stops to think, why does every single woman that comes into labor and delivery have to have blood drawn? They're perfectly healthy. They're just having a natural function of their body, labor. And they say, well, what if she bleeds? What if is the whole
But
what
what
if
is
thing.
that blood result going to do if I don't understand.
Well, if she bleeds, when they say, well, we have to have a clot in the blood bank so we can get blood for her really quickly. Well, what do you do if somebody comes in with an ambulance with a car accident or a gunshot wound? You
borrow
give them
blood.
O-negative blood
give
if you
blood,
have to give
yeah.
them blood, or you type and cross them really quickly. That's the explanation they give. It's the same thing like, why does a newborn baby, for years and years and years, it's beginning to change, but why did we cut the cord right away and carry them over to the warmer? And the nurses would say, well, we have to check the baby out. It's like, well, why? The baby's on mom's chest doing just fine.
The natural way.
Getting its auto transfusion of its own blood. No, we have to cut the cord and take the baby over there. Well, check the baby. If you want to check the baby out, check the baby out on mom's chest. They just do it.
They just do it, correct.
It's habit.
It is. And I'll tell you something that's the scary thing, that most moms are not really conscious and aware that they can refuse that. Don't take my baby anywhere. I want my baby. Don't wash my baby. I want my baby.
Don't wash your baby.
Don't wash your baby, please. Yes, right. I'm not a doctor, but I mean, I learned this from 2 pregnancies.
For at least a couple of weeks. Just you can wash them with water, but don't use any soap or antibacterial soap. Right.
So, but most moms are not aware of these things. So I think that the system is, they're controlling these mothers because they don't know any better.
Right. Well,
they don't know any better.
It's an industry, and look there's a power differential in medicine. There always has been, and the medical model sort of. I'm not saying they get jollies out of it, but they like that way. Because they keep it mysterious. I mean, the history of medicine is fascinating. A guy named Chamberlain invented the forceps I think it was in the 1600s. And his family kept it a secret for decades so that he could charge more because he was the only one doing forceps. He kept it a secret. Now, that's forceps is a tough example because people are scared of forceps. But I'm just saying there's a power differential here. And to keep people in fear is the best way to control them. And when a woman is in labor, powerful. It's too late for her if she hasn't dealt with these things ahead of time because she is in fawning, fight and flight mode. She's not the one. So she needs, either these things need to be with a trusted caregiver, which in the hospital model, again, you have no idea who your caregiver is going to be because it's all pretty much gone to shift medicine.
Yeah,
so you may love your doctor, but you'll have a 1 in 7 chance of having your doctor be the one that's going to be delivering you.
Absolutely.
So in the midwifery model, you're very likely to get the person that's been taking care of you all this time. But you have to plan these things ahead of time. That's why you need to bring a partner who's on board or a doula who's on board who can help to say, no. She said she doesn't want you to examine her right now.
Advocate for you.
Right.
Absolutely.
Because you should stay as far away from your cognitive brain when you're in labor as possible. You need to stay in your primitive brain. You need to keep your mind like any other mammal in labor. When any other mammal in labor is disturbed.
Oh, they get very aggressive, right?
Well, no, they get passive because they're female and they fall.
Yes.
But they put out hormones that stop the labor so that they can get up and run away. You know, the fight or flight thing.
Yes.
They're not likely to fight. They're likely to flight.
Wow.
And so if a deer is in labor and a predator approaches, that deer knows that I need to stop labor and I need to get the F out of here. And only when it's safe will labor return. This way, nature ensures the best chance of survival. And we are no different. We are mammals. When we go to the hospital, contracting every 3 to 4 minutes, and we're asked a series of questions, and we made to do all these stupid things. And then they put you on a monitor, which they don't really need, but they put you on it because that's the protocol. They find your contractions are now 6 to 7 minutes apart. And they're shocked. And it's like, well, if you understood mammalian birth, you'd understand why the contractions have spaced out. They don't always space out, but I'm saying a lot of times they do. And then they say, well, you're 3 centimeters dilated because they did an unnecessary vaginal exam. And then they say, well, you're 3 centimeters dilated. Why don't we just start Pitocin?
Mm-hmm.
And then that whole cascade begins.
Oh, yeah. That's what happened to me. Horrible.
The chance of you ending up with a baby that is born traumatized by cesarean
Yes.
or vacuum because it's got D cells.
Not to mention your trauma.
Your trauma. Yeah. And the baby ends
and
up
the
in the NICU.
postpartum that comes out.
And the postpartum, the rates of postpartum trauma and depression and stuff are high, and they shouldn't be.
They shouldn't be. I agree with you.
And I can
100%.
tell you the difference between the two models. We don't have that kind of those rates in the home birth model. Listen, there are home birth moms who have very disappointing courses. They're not happy with their outcomes, and they're not happy with what happened. I give you a perfect example. I had a woman who came to me with twins. First twin was breech. Second twin was head down. She wanted a home, beautiful water birth. What happened was she was up to the toilet when she was transitioning with the first baby. Neither twin is out yet. And she calls from the bathroom and she says, Dr. Fishbein, there's something hanging out of me. And I'm thinking, well, it's breech, baby. It's probably the foot. And that's the normal thing that happens when when you're a breech provider, you know this, and you're not freaked out by it. She says, no, it's not a foot. It was like umbilical cord. So she had umbilical cord prolapse. Now, if a head down baby, that's an emergency because the cord can get compressed by this big round head.
You could choke the baby, right?
It cuts off the oxygen supply to the baby. Not literally choking. Choking is, and that's different. I don't want people to think choking.
Oh, that's what I know.
It cuts off their oxygen supply. So, but with a breech baby, even though it's a little more common, it's not necessarily an emergency. So we checked the baby's heart rate. The baby's heart rate was fine. We had time for a conversation. I said, listen, you're completely dilated. I can do a breech extract. I can reach up and pull your baby out. And, or we can go to the hospital where they're going to do a C-section on you because nobody there is going to be skilled enough to do a breech vaginal delivery with the cord hanging out. And I'm not going to sit here and wait for hours with the cord hanging out for you to try to push this baby out. So she agreed to the breech extraction. We did the breech extraction. The baby was fine. The second baby came out. Everything was fine. I saw her again multiple times. And then a final visit at 6 weeks, we had a debriefing about the birth. And she was very sort of still, I wouldn't use the word upset, but still sort of very sad.
That it planned out, it made out that way, yeah.
Right. Where even though she got the vaginal birth at home, circumstances were such that she didn't get the one that she had imaged in her brain, and it bothered her. And so you can have that sort of postpartum blues anywhere, but you're far more likely to have it where you are completely disempowered and disrespected, which is more likely to occur in a hospital setting. Right?
That leads me to this question. Is inducing a pregnant woman bad? Because they don't let you full term.
Inducing for non-medical reasons is very bad. Yes.
I mean, when you reach 38 weeks of pregnancy, the doctors start pushing it. Okay, it's 39 now. It's 38 now. It's time.
That is completely unethical and incorrect behavior, unless you have a true indication. A true indication could be something like preeclampsia that's worsening. It could be something like baby's got true what's called growth restriction, not fake growth restriction, which is another topic we might get to, we might not. Or something like, what was the first one I said? Did I say preeclampsia?
Yes, you did say that.
Yeah. Or something like true cholestasis of pregnancy, which is where it's an itching thing where your liver starts to back up, but you have to have a real high number with that, not just a low number where you have this itching, but a high number where you have a increasing risk of stillbirth with a number that's like over 100.
So then what's wrong with leaving a woman up to 40 to 41 weeks of pregnancy?
42 weeks, 42 and a half weeks, 43 weeks.
I mean, that's how they did it in my country back in the day.
There is nothing wrong with doing that.
But they say that
there is a rising stillbirth rate beyond 36 weeks in all pregnancies. That's not the question. The question is, what's the actual rise? Remember, we talked about this earlier.
Yes.
So this, even with singleton head down babies, there's a greater risk of, the longer the baby's inside, there's a greater risk of stillbirth. But what my colleagues don't consider is they don't consider the fact that you're artificially inducing to be an intervention, a problem. They don't see the whole natural process of being beneficial. They want to see a live baby in the bassinet. And so they're constantly meddling with stuff. They're constantly looking at ways to meddle, and they come out with papers that say, oh, we should induce all women at 39 weeks and we'll drop the C-section rate by 3%. Well, that doesn't apply to hospitals that have C-section rates of 30 and 40 and 50%. It applied to an academic institution where doctors are being watched, and there's something called the Hawthorne effect. The Hawthorne effect is just a simple thing that people act differently when they know they're being watched. So put people on camera, like these reality shows where there's cameras in every room. No, people don't always act like that, but when they're being watched, they'll act differently. It's the same thing here. So they get false results. And then doctors, because it meets the model by which they want to practice, they use confirmation bias to choose that article, but the articles that say it's a bad idea, they ignore. And this is human nature.
Wow.
And so with the whole idea of induction, it interferes. Pitocin is not oxytocin.
Yeah.
And baby isn't ready, and the cervix isn't necessarily ready. And nature designed a system. Does nature screw up sometimes? Of course it does. And sometimes that's when induction might be necessary. But we reached a peak of quality probably in the early 70s, as I said earlier. Because everything we've done since the 70s has done nothing to improve the outcomes of the babies we're supposed to be trying to rescue. And yet we've had all these interventions that have led to, like I said, higher rates of cesarean section, higher rates of induction, higher rates of postpartum depression, higher rates of problems in future cesareans, pregnancies because of the cesarean. I talked about placentas growing into the uterine wall, accreta, that sort of thing. That's quadrupled in 30 years. Nobody takes and then no one talks about the effects of a baby not experiencing labor as nature designed. The reflexes it has to go through, the chemical hormonal communication with mom, the microbiome it's exposed to in labor, the handling of the stress of labor might affect the epigenetics of that baby in such a way that it handles stress better later in life. It deals with things differently later in life. Right.
Oh, wow. I didn't know that.
They don't teach that. I didn't know that. I learned stuff pretty much almost every week because of my podcast and because I take dives into things to learn stuff that I didn't know. And I can tell you that most of my colleagues don't know. And only a part of it is their fault. Most of it is the system's fault, that even if they knew, they couldn't do anything about it anyway. But the lack of intellectual curiosity of people that are practicing is also a fault of the system. They're so beaten down, my colleagues, by the hours that they work, by the restrictions put on them, by the medical legal things, by the cost of overhead, by being managed, by having to do algorithms.
And fear.
And by the way, here's a very simple statement. Happy people do not treat other people badly. Yet I hear story after story after story of a doctor who gets huffy because a patient didn't want to do the glucose screening, or they roll your eyes when you said you want to have a doula, or they storm out of the room, or they're short with you.
Yes.
Okay. How many nice, happy people will do that with you? Pretty much zero. My colleagues are generally unhappy. They practice because they're stuck in a hamster wheel and they can't get out. They have families, they have student loans, they have college savings to do, and they're afraid to take the leap. I would suggest to any of my OB colleagues who are really unhappy with what they're doing every day to take a look at maybe getting outside the system.
And you know what's interesting as you're talking?
Because you can do it.
You absolutely. What I thought about is that not only is everything in majority of things in hospital setting controlled, but also the timing of birth. Everything is so quick. I mean, the balloon, when they insert the balloon, right? It's like, okay, maximum. Oh, you'll give birth by 6 o'clock. How do you know these things? They know because they practice this on so many women. Let's induce you. Let's put the balloon. It'll take about 4 to 5 hours for you to dilate up to 9 centimeters. Boom, you have your baby at 6 p.m.
Yep.
You come in at 6 a.m., you're out of here by. I'm
Yeah,
fascinated by that.
you have to ask the question, why do they care how fast your labor is? And part of it, there's two things about that. One is they care how fast your labor is because they have limited space in the hospital. So they want to move you in and then move you out. They don't want you hanging around contracting every 8 minutes. Maybe that's what your body needs.
Yes.
And maybe it takes you 30 hours or 40 hours to deliver. They don't want that. But what's interesting about that and what's absurd about it is if they bring you in for an unnecessary induction, it may take 3 days. And they're okay with that.
Because your body's not ready, right? Your
Well,
body's not ready.
but the irony is that they're okay with a 3-day induction if they're doing it, but they're not okay with you having a 3-day labor if you're doing it. Think about that for a second, right? If nature's designed you to do it and you're doing it differently than their Friedman curve, their labor curve, we have to intervene. But if we're intervening and you're not doing enough, we'll just keep intervening and keep intervening and keep intervening, and we'll turn it off and let you rest, and we'll start again the next day. It's like, no, just send them home. Why were they there in the first place? If it was that urgent to get them delivered and you can take 3 days to do it, maybe the reason for induction wasn't there in the first place. I often ask women who tell me about their story of their first baby that they had an emergency C-section. And I say, okay, did your doctor say it was an emergency C-section? Yeah, he said it was an emergency C-section. Okay. When they decided to do the C-section on you, how long did it take them to get you from the labor room into the operating room when they started the case?
Hours
and they would sometimes say, 45 minutes, an hour and a half. If it was 45 minutes or an hour and a half, that was not an emergency C-section. Yet they used the language to, I'm not sure exactly why, make themselves feel more likely. Maybe they get better insurance reimbursement. I don't know. But it wasn't an emergency C-section. It was maybe urgent, or maybe it was just time for a C-section. But they make the woman believe that all the interventions that caused you to have a C-section in the first place don't matter. But the fact that we did a C-section and were able to save your baby, look at how great we are. We caused all these problems. Now we're fixing the problem. Look how great we are. You asked earlier about, we never really answered the question about, what if this happens at home? And I said, essentially, these things generally don't happen at home when you don't meddle with labor. Occasionally they do. And then you have to call an ambulance and you get to the hospital as fast as you can. But the idea that if you have a true emergency at a hospital, like say you have a placental abruption where the placenta separates and the baby's in deep doo-doo, right? Well, you often only have somewhere between 6 to 14 minutes or so to get that baby out before it's going to suffer irreversible damage. Now at home, that's not likely to ever happen. You're never going to get to the hospital and get that baby out in time. But I can tell you, most hospitals can't get a baby out in 14 minutes either. They can't get you back to the operating room, get you on a table, make sure they have a team of surgeons available, make sure the anesthesiologist is available, make sure the scrub team is available, and get that baby out in 14 minutes. There are certain hospitals, like Cedars-Sinai, which has OB residents and dedicated obstetrical anesthesiologists. They can probably do it. But smaller community hospitals, they can't do that. So just because you're in a hospital does not mean it's safer. And it's probably, in my opinion, again, less safe because you're more likely to end up with that whole cascade of interventions that leads you to a C-section rate. I mean, look at the difference. I said our practice, the midwifery practice that we had with the collaborative midwives that I talked about at the very beginning, we had a 7% C-section rate, and we took all comers. The busiest practice in that hospital was about 3 doctors, I think. They saw about 30% more patients per month than we did. Their C-section rate was about 24 to 25%. Now, this was again in the 1990s, and that was about the normal rate. Now it's up to 32. But so their C-section rate was 3.5 times higher than ours, with the only real difference being the model by which we managed, and I don't like that word, but the model by which we cared for our moms, the midwifery model of care. If our women broke their bag of waters, we told them to go to bed. If their women broke their bag of waters, they told them to come in and they started Pitocin. They did lots of vaginal exams on them. They didn't do breaches. They didn't do twins. They sectioned them all. They didn't support VBAC. Their VBAC success rate was pathetic. Ours was really high. Ours was over 93% with our VBAC success rate. So again, not tooting our own horn, I'm tooting the model of care. The model of care with midwives who are well-trained, who are patient, who are trusting and honest, is the best model that there is right now. And it's been that way since the dawn of human history. I'm reading a book right now called Reclaiming Childbirth, A Rite of Passage by Rachel Reed. She's a Australian, and we're going to have her on our podcast in a couple of weeks.
That's
and
awesome.
So I'm obviously listening. I'm not reading. I'm audibleizing her book, and again, I've read a lot of books on the history of obstetrics, and her summary in the first couple chapters of how midwives went from being the birth keepers and the caregivers and all that to becoming vilified and then witches and then burned at the stake. And then, we have a modern day witch hunt going on for midwives now. They're not burning them at the stake, but they're sicking medical boards and nursing boards on midwives. Hospitals will report midwives all the time for doing things different than the hospital would do them.
Mm-hmm.
And because the hospital thinks that they have the market on what's right and what's wrong, they report them. And then the midwives have to spend time and money to fight them. Correct. And midwives don't have time and money.
I mean, they report parents.
Yeah, Child Protective Services is a whole nother thing, and
they report parents. I mean, how?
Yeah,
not
if you
to
don't,
that
if
extent,
you don't give your kid hepatitis vaccine, they may report you to Child Protective Services.
That's what happened to us.
Did it?
Yeah.
Do your listeners know that?
Yeah, I'm very open about that.
Okay.
Yeah. But I'm very open about that.
That is an unbelievable violation of medical ethics, and I wish someone would sue their
but
ass.
not to mention the non-vaccine policy. Like, you cannot. I mean, doctors now are not even wanting to see you if your child isn't vaccinated. So who do you go to? It's always these punishments.
Well, you consider yourself lucky, by the way, if a doctor says, I won't see your child unless they're vaccinated.
That's the law now.
Because that's not the kind of pediatrician you ever want to go to. Mm-hmm. Well, people have to choose what they want to do with that law. Mm-hmm. All right. They can homeschool. They can move. But if you have a state that wants to stick toxins in your baby without any proof of benefit, then you have to decide, why are you voting for these people? Yeah. Why do you keep reelecting Dr. What's his name? Not Ted Lieu. Who's the doctor in Sacramento who just keeps pushing all these things? I'm glad I've been out of California now for 2 years. And there's a doctor there that pushes all these vaccine bills. He's a maniac. He's an idiot. And I would love to sit and debate somebody on a stage with a live audience.
We should come up with something like that.
Oh, they won't show up. I can pretty much.
The show won't live.
You know what? Look if I was president of the United States back in 2020, whether I was Trump or Biden.
Are you a Trump supporter, Dr. Stu?
I am.
Yes, give me 5 on that.
Oh, well, I'm more of a government sucks supporter.
Yes.
And therefore, I mean, the only one that's really reasonable. I mean, RFK Jr., I like a lot of what he has to say, but he won't.
Oh, he's very
won't
real.
win. But let me get back to my point.
The guy speaks truth.
My point was in 2020, when we were debating all this, there was no debate. It was like, do what Fauci says, do what Deborah Birx says. If I was president, I would have had Dr. Fauci and Deborah Birx on a 2-hour live national broadcast debate on the stage with guys like Jay Bhattacharya and Peter McCullough and have them debate stuff. Why wouldn't we do that for the American people? And because those guys wouldn't do it. They wouldn't show up. Right. And if I was president, I would have made them show up. But unfortunately, our presidents, they know stuff about stuff, but they don't know much about, they're not an expert in anything. And so they rely on the experts.
Yeah.
And I'll tell you should never let experts govern because experts have such a narrow,
I agree,
blinder vision on.
I'll tell you, my 5th grade English teacher said, always question authority. Always question. And that really stuck with me because you cannot always go by what experts say. You have to have the knowledge and the education to at least do a little research yourself. And I think that today, these women, these families, men and women what they're going to take away from this podcast is do your research. and learn about the birthing process. Don't always go and listen to your physicians. Have an open mind.
And don't buy the thing that though this is for your own good or this is for your safety. There's a famous quote by the French philosopher Albert Camus
I love
that
Albert
goes,
Camus.
the welfare of humanity is always the alibi of tyrants.
Oh,
And this could be dictators, but it could be the person running your local school or
Mhm.
whatever. We're doing this for your children's own good, or we're doing this for your own good.
never mind what that's like for you.
Safety is one of the arguments, and what was it, Ben Franklin or somebody else that said those that would surrender their more liberty or their liberty for a little safety deserve neither. I butchered that quote, but there
You did fine.
but there's something
sure.
about that where if you're going to surrender your liberty for the appearance of safety, then you probably are going to get neither. You're not going to get more safety, and you're certainly not going to get, it's freedom, not liberal. Surrender your freedom for safety. And we all did that. Look what we did
Yeah.
in 2020.
Yeah, that's true. You know what I learned from you? Not to ever be led by fear.
Yeah.
I love that. I've watched a lot of your shows, your podcasts, and that's one of the things that you guys, I want you to really process that statement. It's so powerful because when you're in that delivery room, you're in fear.
Yeah.
You are. And it's very scary and it's understandable, but don't ever be led by that.
That's why you have to go in. You have to go in be prepared. You have to educate yourself. If you're uneducated, then you can be fearful. Great line from the original Batman movie with Christian Bale, the first one. It says, he's talking to the gangster, and the gangster says, you always fear what you don't understand.
Yes.
There's more to that quote, but by the way, it's a great scene in that movie. That guy who played the gangster was a good actor, and he had me convinced. But you always fear what you don't understand, and the reason that we keep things a mystery sometimes is so that we can control you. And then I read a book a couple of years ago by a guy named Matthias Desmet. It's called The Psychology of Totalitarianism.
Ooh.
And it's about something called mass formation. And it really discussed about what's going on with COVID and how they took people who used to be friends with you, your family members who loved you, your neighbors who loved you, and with just a little bit of manipulation, they began to turn on you, and you were uninvited to the weddings, and your neighbor called the police on you because you had more than 6 people in your backyard.
It's still like that.
Right. But how does that happen? And the book defines it. It's kind of like the example he also uses is Nazi Germany. It goes in the 1930s, Germans lived side by side with their Jewish neighbors. And they were always a little bit like the Jews are miserly and the Jews did this and Jews did that. But the kids played with the Jewish kids and they lived next door. And within a matter of a couple years, they were turning the Jewish families in, and they couldn't wait to then pilfer all their furniture and all the stuff from the Jewish homes. How did they do that? Well, they vilified them. They started to point to them as the cause of your problem. And so what happens is in order to be part of that society, a person gives up their individuality to become part of the collective. And then when the collective is challenged, they get very, very agitated and they go after the people that challenge the collective. So anybody like me, or like if you people know who Del Bigtree is, who has the high wire, or anybody in the history who's challenged the status quo has generally initially been vilified.
Yeah, prosecuted,
persecuted, killed,
definitely
ridiculed. And if they do that to you, that's the defense of somebody with no argument. You should know right off the bat that when they're attacking someone personally, that person is probably correct.
Exactly.
And when they call somebody who's saying they have it's a conspiracy theory, anybody who says that is probably the one with the conspiracy theory.
I agree with
and the
you.
other person, because they always tend to label you with exactly what they're doing.
Yeah, exactly.
And when the medical model says that home delivery is for pizza, all right, that's an old slogan for a while. That's somebody who has no understanding,
no knowledge of absolutely.
Right.
It's a very broad
and they don't
statement.
really care what women want. They
No.
don't have a clue as to how important childbirth is to the woman and
journey.
how she gives birth
Yes.
matters to her. They don't have any understanding of history.
The empathy.
There are cultures where women, if they don't give birth vaginally, they have no
Yes.
standing in the culture whatsoever.
That's so true.
It's
Yes, I've
mean
read
on the
about
part of the
that.
other women in the culture, but it's part of their culture.
It is.
And the paternalistic medical community comes in And they says, well, all that matters is a live baby in the bassinet. It's like, no,
Yeah.
that's not all
How
that
many
matters.
times do you hear that today? A lot.
Right. We've sterilized birth.
Yeah.
We've sterilized death. Most people in their life, they go through life with never seeing a baby born, and they never see somebody die, except on television.
Yeah.
They don't, because people die alone or in a nursing home or in a hospice. They don't die in the home anymore, and people aren't born in the home anymore.
Yeah.
There's an interesting foreword to a book. I think it's a foreword to Ricky Lake's book, I think, written by Jacques. I can't remember Jacques' last name. He talks about how he was walking around New York one time, and he saw a little plaque on a house, and it said, "The birthplace of Teddy Roosevelt." And he said, isn't it interesting that probably from this point onward, the only time you're ever going to see a plaque like that will be on the stairs of Cedars-Sinai Medical Center, or or at Lenox Hospital, New York, or something. You won't see a brownstone anymore with this plaque on it that says somebody was born here, but that's where they were born 100 years ago. And within 30 years, the medical system took over, and they took birth out of the home and put it in the hospital, and they did it in the name of safety. But in the process, they couldn't just argue safety; they had to vilify midwifery at the same time. But they're now less safe. We've gone. The pendulum has swung way too far. Women need to take back childbirth. They need to make these demands. If you demand it, there will be someone who will supply it.
And it's
but
up
if you
to us.
If you continue to bow down to your insurance card, then you get what you deserve.
Wow, I love that. Take that. We need to take our power back. Families need to take their power back for sure.
Yeah, doctors don't. I mean, listen, obstetricians don't know anything anymore. They really don't. They don't. They cannot think out of the box.
No.
Either because they don't want to, or because they're not allowed to. I don't care what the reason is. But pretty much everything that they do, everything in the obstetrical model that I learned when I was training, everyone gets an episiotomy. Everyone's in lithotomy position, which is laying on your back with your legs up. That's like the dumbest position to give birth in.
So uncomfortable.
Birth is a sterile procedure. No, it's absolutely not a sterile procedure. C-section, yeah, it's a sterile procedure. Birth itself, not a sterile procedure.
It's natural.
Delayed cord clamping, we can only allow 1 minute because otherwise the baby will get too much blood. It's the baby's blood. It's a circulation. What goes in comes out. And name another mammal that someone rushes in and cuts the umbilical cord. Try taking a baby chimpanzee away from its mother. see what happens to you.
Wow.
Oh, I'm sorry, Mrs. Chimpanzee. We need to take the baby over to the warmer. Whack.
Yeah.
Okay.
You're done.
Right. You're done.
Yeah.
But we do that, and we just fawn.
It's just interfering. A lot of interference.
Women have been taught to just fawn.
Yeah.
Just defer. Don't do it anymore.
Which is a nervous system response, you guys, by the way.
Oh, they don't know. Your listeners don't know that.
Well, I'm sure they do, but just for anybody that doesn't know,
it's trying to please. You're trying to please your captor, basically.
Exactly.
You just fawn, right?
Yeah. Dr. Stu, thank you so much for today.
That's it.
That's it. I want to go over like 2 hours. I mean, I can talk to you for hours and hours.
I'm kidding.
You are so knowledgeable. You need to be protected. You do, because not a lot of doctors talk about things like this.
I'm doing great. I love the fact that I feel very comfortable and confident in what I'm talking about, that I can back it up. There's data to back what I'm saying.
Absolutely.
But you don't always need data to prove something. You don't need data or a study to tell you it's safer to cross the street when the light is green.
Yes.
All right. Common sense has been beaten out of us.
Yeah.
If something doesn't feel right in your gut, it's probably not right. So question it. And if what your doctor's telling you doesn't sit well with you, then question it. And if your doctor doesn't give you the time of day, then seek a second opinion. There's nothing more valuable to a woman in her lifetime than how her babies are born.
Oh.
It's not. A wedding day is really great. Graduation day is really great. But the thing that you'll remember most when you're 90 years old will be the day your children were born.
Yeah, and you got me emotional.
And
there.
I'd like to give women better memories.
Yeah.
That's all.
I love that. We'll end with that because that was very beautiful. Okay. Thank you so much.
You're welcome.
You guys, I hope you enjoyed this episode.
Me.
Of course,
I'm
it's
glad
an
it worked
honor.
out.
I know.
And you have a lovely studio. It's great.
Thank you. You're awesome. And I'm so grateful for you for speaking up. There's not many physicians who will do this. I know that you know that. So I think that you definitely are a type of person that needs to be protected and praised because you're doing this is God's work. honestly.
Thank you, Edith.
Thank you.
Thank
Of
you.
course. Thank you.